Hey, this is Brandon Steele, one of the presenters. Today's lecture is on game changers. And game changers is a generic description. However, it's the nuggets, the little small articles that come out on a regular basis that can really change the way we practice and change the way we think about conservative care of musculoskeletal conditions. I'll go into pain as kind of a common theme for these game-changing articles. However, we're going to talk about everything ranging from hip problems up through shoulder problems, through elbow problems, and really gain some insight into what the research is telling us on what we can also do for patients who maybe aren't progressing like they should. I have a very simple mantra in my practice. It's that I expect to see all my patients for life, however, not for the same condition. If I was going to see someone for 30 years for the same low back complaint, I would get tired of them. I would feel like a failure. So I do think we should see patients for life. And really the evidence says that chiropractors are best suited to treat patients for life for conservative measures for musculoskeletal complaints. And I'm going to go through a lot of that research that's just come out in the last year and hopefully bring some insight into maybe some other things that you can treat. And then I think at the end of that, we'll even cover how we can position ourselves within our community, utilizing the evidence, utilizing the things that we can do to hopefully build a network of providers that have a very similar mindset. So today what I'm going to do is to teach you everything that the internet tells you about chronic, persistent, or ongoing pain. Just kidding. We can't do that in 2 hours. However, I am going to give you 3 ways that I think are insertion points to treating pain. And I think that you might find the logic a little bit different than most, but I guess that's why we're here. We're here to maybe look at a different insight and a different principle behind how someone treats. But if there's going to be 3 solutions to a problem, we need that problem. So let's go over a quick little case study. Shouldn't say case study, maybe a demographic of patients. And I see this all the time, and I think that if we're given the privilege of helping people to understand their pain and how can they recover from it, then we really need to be obliged to really know what we're talking about. And it's going to require some serious thought that maybe we had in school. However, now we can exploit that when we start to see patients. We need to make sure that we don't facilitate pain rather than just treat persistent pain. So let's all think about that patient, and you're going to know what patient I'm talking about very quickly. The patient that came in to see you, it's 3 days before a holiday, and they've had pain for 10 years, and let's call it headaches. And these headaches are not a 10 out of 10, they are a 20 out of 10. But they come in to you and they have a 10 out of 10 headache, and they want this pain gone yesterday. They've already seen everyone, and you're their last chance. And they come in and you do what you do, and you're a little nervous when they leave because they've had it for so long. They've already seen 7 chiropractors, an orthopedist, a neurologist, physical therapy, acupuncture, nutrition, and what have you. However, you do your thing. And when this patient leaves your office, you're pretty excited, and you take a look at all their imaging, and their imaging doesn't really have anything significant. Their imaging is some structural stuff in the neck, in this case a hip, and it looks kind of bad as far as some arthritis and some disc problems, but their pain really doesn't match their structure, and furthermore their function doesn't match their function, and I think that we need to really have an idea on what's wrong with this patient before treating. But this person's so complex, and they have one of those graphs on your intake form that everything's colored in, and I think that they've labeled themselves as a headache patient, and maybe they were told they had a disc problem, or maybe this person was told they have a hip problem, unfortunately we get paid based on labeling people's problems. The problem is that it's wrong. The problem is that labeling someone's condition based off their structure, an x-ray, in this case a hip, in my patient's case a neck, isn't correct. And when you have people who have chronic long-term pain, it's sometimes impossible to educate them, I should say that differently, to re-educate them on how they think their structure is related to their function and how that all is related to their pain. And the correlation between those. This patient that came in with the headaches, maybe they had a car accident when they were 6 years old. Maybe they had an incident where they fell out of a tree or bucked off a horse. And they relate everything back to that problem. Today we're going to cover this patient. We're going to cover these chronic, ongoing, long-term pain patients, and maybe sometimes it is just not the site of imaging that's their problem. It's not the anatomic site of dysfunction. Rather, it's possibly the structure and the function are at different sites in the body. And this chronic, ongoing pain processing is not happening here at the hip. So let's talk about this headache patient. And Dr. Bertelsmann coined this name, so I'm not going to steal his thunder, but he calls them checkmark patients. And a checkmark patient, similar to our headache pain patient, is just when their symptoms and their tissue injuries really don't correlate. This is your headache pain patient. They come in at a 10 out of 10, and let's say this patient, Mary, who came in with her headache at a 20 out of 10. The next time she sees you, where's her pain? Her pain's down at a 1 out of 10, a 0 out of 10. That's the patient with degenerative neurogenic claudication that comes in, and the next day they're 50% better, and they've had that problem for 30 years. Something doesn't add up. Something really just doesn't make sense, because that anatomy and that physiology shouldn't respond that fast. So I'm left with two thoughts. The first thought is I have magical hands. And we've all had that thought process, like, damn, I'm good. I can heal anyone. Let's just agree that's not the case. It's just not the case. It's not scientific, it's not plausible. But I do think there's something to that. I just wanted to find out what that is, because the next time they come in to see me, that third time, they're at a 30 out of 10. They're worse than they've ever been. And I just want to go home and cut off all the tags on my mattress and kick the dog, and because I just don't understand what's going on. How could this person in so much pain and discomfort come in at one point, feel so much better, and then get worse as the days go on? And I began to realize that the tissue injury and the structural changes aren't the only variables resulting in this degenerative model. The degenerative model is thought to be pathoanatomic. It's thought to be something that the meniscus is going on the knee, or the degeneration in the back gets bad at, and it's causing pain, but we know that's not true. And hopefully I'm going to bring some insight into that in the next couple slides. But I think that there's other variables that we need to attack. These are the variables that add up to create the painful conditions and the diagnoses and degenerative syndromes. And I think it can all be explained through one process. It's a learned mechanism. There is a learned mechanism of pain, and we instill this in our kids. We propagate that through life. And I think that as managers of pain, for most musculoskeletal conditions, chiropractors have the ability to have an insertion point into these three parts of our body that really propagate or learn to be in pain. And I think that we're going to hopefully hit on that today. It starts with the diagnosis, but it carries on through the types of treatments that we do, the referrals that we make, the manipulation, the mobilization, the patient education, the rehab. Those are all the things that make the difference and how to impact these checkmark patients. And it's not changing their structure, It's changing the way they learn to respond to pain. Let's take, for example, this. Let's take someone with a tendinosis. Dr. Berlesman will go over a little bit about the elbow and the shoulder with tendinosis, but let's say I've got a muscle that has a specific function. That function is to be elastic. It's to contract and relax. And I go through some repetitive stress or maybe just postural stress, and these strands don't contract or relax like they're supposed to. And let's say I'm a painter of a ceiling, and I keep on painting ceilings for 30 years. Eventually these muscles get tired and they form tears in the muscles, and depending on where that structural problem is usually dependent upon the age of the patient, which I'll cover in my lecture. And these don't move quite as well. The one possibility is to not be a painter anymore, and we see that a lot with disability in today's world. However, the other possibility is to get this moving. The problem is when you try to get this moving, it also causes some discomfort. You're trying to stretch tissue that really doesn't want to stretch a whole lot. And I think that the patient education piece of this needs to be, hey, Billy, we're going to do these exercises and you're going to have some discomfort. In fact, I expect you to have some discomfort. In fact, discomfort at a 3 or 4 out of 10 is expected and anticipated. Versus telling somebody they have tendinitis and we need to rest that area. Oh, just take a couple of days off work. Well, that may help take away the pain right now, but it's not going to take away the pain in the long run. As soon as they go back to their activity, that pain's going to happen again. So we need to have the tissue respond to our therapy and our education so we can get them back to normal life. And this is a process. This isn't a unique process to our patients. This is a unique process to everybody. And I think that most of us look at the pain process as a process that moves up the chain. So we've all seen a kid fall. Any of you who have small kids, you've seen your 3-year-old fall in the concrete after riding his bike or a scooter. And what does that kid do before anything else? That kid gets up and looks around. He doesn't even see blood. He doesn't even know what pain is. He falls, then he sees blood come down, and he's looking for what? He's looking for your reaction. He needs to know how to respond to that injury. He thinks he's hurt himself, but now when he sees that blood, he's like, okay, blood, mom's running toward me, I got a burning sensation in my knee, I need to cry. And unfortunately, he has learned to take a peripheral nociception and turn that into a central process. Now, the next time Johnny sees blood, even though it didn't even hurt that bad, what does he do? He starts to cry because he knows that's a bad thing. We can also have this from the top down, which later on in life, you start to have a certain amount of stimulus come in, and you can remember past experiences or past movies or things that happen. You're like, oh, wait, I know what's going on here, and you know how to respond. Let's play a little game here. So I'm going to show you a picture and let's see how you respond. So here's the picture. We all see a snake. We all see the same snake, the same picture. How did you respond? How did you respond when you saw this picture? Your response is based on your memories of this stimulus. So some of you may have this response. This kid plays with snakes. Unbelievable. I guess it's 2020, so I guess people can do whatever they want. However, the touch, man, the feel of a snake is pleasing to this person. He's got a smile on his face and this thing that could literally kill him. So he has a much different response to this stimulation than I would. In fact, when I was 11 years old, I was bit by a water moccasin. I was riding around on a jet ski in North Carolina. We were in a river creek type area. I got thrown off and I was bit by the water moccasin. Severe pain, didn't really know what was going on. It was unrelenting burning. I have a very different response to when I see a snake. this is what I would do. When I even just see a snake, my blood pressure goes up. I get tense, I get nervous, I could sweat, my heart's going to race, because my body interprets this pattern of stimulation different based on my experiences as compared to the other kid who has a much different experience, and it's created a lasting memory in myself that I have learned to not mess with that, because that memory has created a physiologic change. It has actually rewired my brain, modulating everything from my heart racing to my immune function to my legs having superhuman strength and running as fast as I can away from that snake. This is the same thing that happens, and while these seem like remote experiences, I don't think they are when it comes to our practice. Is that for our long-term ongoing pain patients, we need to reshape their memories. We need to find insertion points into their painful problem that isn't just manipulation. It's not just adjusting the area, putting our hands on the person, doing acupuncture, doing a functional exam. Those are all important things. However, we have to attack each patient for their experiences and really go after what's causing the problem, what's propagating the problem, and their thoughts about that problem. I have to admit, my lowest grade in chiropractic school was psychology. We all had to take that class. It was the last class of my tenure at Logan College, and I had a very high grade going into the final. And I was talking to my professor as I was walking into the final, and he said, "Oh, Brandon, I'm surprised to see you here. You don't even take the final, and you still passed the class." And I'm graduating in a couple weeks, and I said, "Great, I'll see you later," and didn't take the final. And I did get a low grade, and it still haunts me to this day that I took the easy way out. However, psychology is something that we all have to do understand psychology on a daily basis to deal with chronic pain patients. So let's talk about this. Let's talk about a case. And I really think that this is where the true gold of this presentation comes in as far as game changers. I've got elbow pain. Patient comes in with elbow pain, and we have a couple options with this patient. I can point to it and I can say, yeah, you've got elbow pain right there. Just stop moving it, rest it, relax. Whatever you've been doing has caused the problem, because you're going to start to compensate around that. In fact, don't go back to work for a couple days. And I know this is causing some issues with sleeping. Take some ibuprofen, don't pick up your grandchildren, take this pain reliever, and do this stretch. Is that a good thought process for this kind of medial elbow pain? That's what a lot of people do, because I can point to it, I can say it's tender, it's pain, and maybe I do an orthopedic test that has pain upon resisted forearm pronation, or I do any kind of wrist flexion with that patient, and it reproduces medial elbow pain. My knee-jerk response is I've got medial epicondylitis. The person did some activity and it causes some pain. What I can tell you is I can get onto ChiroUp. I can look for the exact recipe on how to get people out of medial elbow pain, and I can do it quickly. I can find where the injury is. I can do some ice on it. I can do some ultrasound on it. I can make sure there's no issues with the median nerve, and I can do some stretching exercises with it. And if that's all the information that I have, I can do a pretty good job with that. However, what if they have cubital tunnel syndrome? Cubital tunnel syndrome is when I don't do a good enough job, and let's say they actually have compression of the ulnar nerve in that region. And they're still going to have that medial elbow pain, but if I didn't do the right ulnar nerve tension test, if I didn't ask them about nocturnal symptoms, most of your peripheral neuropathies are more persistent at night because of that inflammatory response. If I didn't check the elbow flexion test, if I didn't do Tinel sign, then I would never know that this person had cubital tunnel syndrome. And if I just took the patient at face value and said this only happened once and it's not a repetitive issue with, let's say, running where they're keeping their elbows flexed the entire time, or they're a carpenter, then I would just take them and give them a couple days off and not dig a little bit deeper and find out, if I did just a couple more tests, that this is cubital tunnel syndrome. What happens if they're not even skeletally mature? Let's say it's an 18-year-old and they come in and they've got pain at the medial elbow, and I said, oh, medial epicondylitis. Well, when they're not skeletally mature, what is really probably going on there? I can have an avulsion injury at the actual elbow, like a Little League elbow, where they're having an injury where it's actually pulling, the tendon is stronger than the bone and it's pulling away at that growth plate. I need to make sure that I understand that different parts of the body have different problems, meaning you're not going to have closure of those growth plates until a certain age, which is why we see this in Little League's sports so often, is because that is the weakest point. And what I'm getting at is that if we just point to a certain diagnosis and say, oh, that's low back pain, that's elbow pain, that's hip pain, that's not good enough. That's not good enough. We have to classify everyone as their exact diagnosis. And when we can do that, it's not for us to feel good about that diagnosis. It's that when we know that when you're before skeletal maturity, you're at more issue for a bone problem. After that, more of a tendon issue. If it's acute, it's more of a tendonitis. If it's more chronic, it's a tendinosis. After that, it could be more of a degenerative condition of the joint. Those are the things that make all the difference, because that's the difference between me giving someone a day off versus me actually going in and rehabilitating the patient. These have very different treatment plans and different processes, meaning I can change the way someone moves. I can change the slot arm of their ankle when they throw a ball to help avoid this kind of pain. What else can I do? I can tell them to take a little bit more rest. The average pitcher, if you're looking at the strains on an elbow, it's astronomical, and it becomes apparent in a pitcher at a young age. However, that quadruples once they hit pitching at the major league level. It's the equivalent of the strain on the medial elbow as far as the distractive forces as putting your arm in a vise. I'm not going to be able to show this very well. Arm like this with your thumb down, and then drop a 25-pound weight in it. And as it goes down and it pulls at that medial elbow. Now do that a couple hundred times a day and see what happens. So this is something that I could say, well, yeah, that's a lot of stress. So we need to stop that. That's one way of looking at it, but the current train of thought is to not look at it that way. And I'll go through the studies here in a minute, but it's more about progressive loading, is building people up to that activity. What do we see now in college sports? We see a crazy amount of people getting injured because people have not progressively loaded their body to the point where they can perform that activity. It's very similar to a couch to 5K run. You'll see some people plantar fasciitis, some people with meniscus problems, some people with hip problems based on going from very little activity to a lot of activity. So the difference between these patients is that someone with tendonitis who's in their 20s and 30s, ice and rest may be a good idea. In that respect, taking them off of work and doing some stretching might be a good option for this person. However, someone who has a tendinosis, someone who's a little bit older, someone who's had this condition for several times, every month they get it, twice a year they get it. Well, then, just stretching and relaxing isn't good enough. In fact, they need to create a localized inflammatory reaction. They have an osis. They have something that needs to be addressed. In that respect, creating a controlled inflammatory reaction would be the best option. Doing things like instrument-assisted manipulation, your Grastins and your factors, using those kind of tools. Going after eccentric exercises, getting in there and roughing that tissue up. Dr. Burrell's going to talk about that in this conversation between itis and osis in part 2. However, if I just looked at someone's elbow and said, you have pain here, be nice to it, rest it. If they have tendinosis of the wrist flexors, yeah, I might give them some short-term relief from that pain, but that chronic, persistent discomfort and that chronic weakness at that area, as that tendon is the weakest point in someone who is skeletally mature, I'm not doing anything for them in the long run. And let's say they do come in to see me and I do get them out of pain because I saw them 6 times over 2 weeks and they stopped work. What's going to happen in a month? It's going to come back, and what are they going to do then? They're going to go see their real doctor. They're going to go see a physical therapist. They're going to see another chiropractor. They're going to see acupuncturists. Whereas if we just had the right diagnosis and we labeled them appropriately, we would know the recipe and how to get them out of pain and to keep them out of pain. Performing the right test for the right patient at the right time helps you. I think one thing that I've seen with young practitioners is they try to speed up their treatment time with patients. And I think that might be a little bit backwards. I think that if you can really speed up your evaluation time, then you only perform the treatments that are necessary. For these kind of patients, if I did, someone had medial epicondylosis and I do ultrasound and I do stretching and I do massage and I manipulate some stuff, that's wasted time. Yeah, it gets them to feel better a little bit. However, it doesn't actually fix their problem. So if I just have the right evaluation, then I can arrive at the right type of treatments. Let's say they didn't have those. If they had cubital tunnel syndrome. If I had cubital tunnel syndrome, what we know, especially with thoracic syndrome, is that 20% of people who have thoracic syndrome have issues in the ulnar nerve. Well, the treatment for that is to stretch out the ulnar nerve. That's a big component of their pain. Doing things like the ulnar nerve floss may be in their future over and above the resting in the ice. And let's say they're a little league elbow. Now what do I do for them? Do I rough it up and create a localized inflammatory reaction over a avulsion fracture? No. Do I teach them how to do eccentric exercises over the little league elbow? No. There's someone where I need to teach how to rest. I need to teach the appropriate mechanics. So you can see that based on the age of the patient and based on their diagnosis, I can have very different strategies on how to insert myself into their care plan. But it all starts with the actual diagnosis, the evaluation section of what we do. That is another benefit of doing virtual seminars. I can drink coffee the entire time, and I don't need to stand up on a stage. So that's one plus for the virtual summits. The part that I'm going to get into with the Game Changers webinar is this kid. So, if I told him he had little league elbow and he just needs to stop playing baseball, that's not good for a little kid. I need to make sure that I give him the proper education because he's going to take 2 paths. The first path is going to be to fight through it, which a lot of kids, mostly because of their parents, will force them to do. And the other path is to compensate around it. They can change their slot angle, they can move their hips, and they can find different ways to get around that elbow pain. Now, we want to make sure that we address that with our patients to prevent future injury. Because here's what I know, is that when you start to look at the current research behind shoulder pain, elbow pain, in this case, pitching mechanics, it's not just the elbow. And we know that as chiropractors is that when someone has a localized pain, an anatomical, even site of dysfunction that we can see on imaging, that doesn't mean that's where the problem is. That just means that's where they're having pain. They found their weakness. I always say, congratulations, you found it. Now we need to find ways to decrease the load to that area, in this case, a little league elbow, and then find why that's being overloaded. In this case, I would pronounce the author's name, but I can't, is that this is one thing that I think that is very much overlooked is the plant foot. Looking at somebody with pitching mechanics that go a little bit awry, you need to find out how they're stabilizing themselves. And what we know is that that first foot, the opposite foot, in this case it'd be a left foot as he's a right-hander, that has to hit the ground. It needs to stabilize itself. It needs to have the ankle over the knee, over the hip, to create a good base of support that he can catapult the baseball towards home plate. And in order to do that, he has to have good mechanics. When they do this over and over again with that torso rotation, they really force hip flexion and internal rotation, which you can really see at this with this young man. And we start to develop a dysfunction there. It could obviously turn into an impingement syndrome at some point. Femoral acetabular impingement. So that's something else that we can attack. Don't just look at the shoulder. I know Dr. Winchester always uses the Dizzy Dean example that I believe he took a baseball off his toe and he never pitched the same after it because he had that pain in his foot from the baseball hitting his foot. And you wouldn't think of an elite pitcher as having a career-ending injury to his toe. However, that's where the kinetic chain begins. But if we have that understanding this elbow pain is probably due to the way this person is moving, then we can have an understanding on how to fix this problem. Does that mean that you and I need to be the masters of pitching mechanics? That we need to do strength training and Olympic lifts with all of our patients? That we need to have a gym in the back of our clinic? Hell no. That's not what some of us do. Some of us may do that. However, this is the point where you can really insert yourself in your community and to carve out your niche. My niche is pain relief. I'm looking to get people out of pain as fast as possible, teach them about their problem, and to never see them again for that condition. I tell that to every single patient. And the reason I do that is that's my brand. That's what I do. However, I also recognize that I can't do that alone. Sometimes I need an injection from the patient's primary. Sometimes I need physical therapy because it's a frozen shoulder and that takes a lot of time out of my day to rehab that. Sometimes they need a massage therapist, sometimes they need a psychologist or maybe a nutritionist. So we really need to focus on all the aspects that lead to this problem. If I don't correct internal rotation of the hip and I don't get them into more, in fact, I would do some directional therapy as far as some extensions of the hip and external rotation to force a little more full range of motion around that joint, then Johnny here is going to keep on having that pain over and over again. So what I'm getting at is dig deeper. Don't just look at the anatomic site of dysfunction, look at the whole person. And don't think of past research and past thought as what you need to give to your patients. What we know is that, pitching mechanics and curveballs and change-ups, they're not it. They're not the problem. Our bodies are designed to bear load, to create force. And we really look at the stuff that we learned a long time ago, whether it was in school or whether it was from our parents or an old coach. And we've taken those things as facts. And when it looks at this paper from Oliver, I think this was 2019, yes, is that we really need to make sure that we keep people rested. We need to make sure that we understand that it's the rest time. It's the ability to heal. Everybody's body has capacity. And yes, we can build that capacity through strengthening, but as long as you stay within that capacity, your body will always heal. The problem with Little League sports is that we just don't give the kids time to heal. I have a 13-year-old son that when he plays in a baseball tournament, we travel to a location. We practice 3 times that week. We travel to a certain location. We have a practice on a Friday. He plays 2 games on a Saturday. Hopefully they do well enough. And then what happens on Sunday? You have the possibility of playing 3 games. that's just not acceptable. It's not going to let that body heal in enough time. And the worst part about that is you'll see the better players get utilized the most. What does your pitcher do as soon as he gets pulled out? He goes and plays shortstop. He goes and plays catcher, and he's throwing the ball nonstop. So really taking those things into consideration and taking the new current research and backing off maybe your current thought and saying, well, maybe this is a little bit different, and I can educate my patients differently. The last part about this is scapular dyskinesis. Is that there's a lot of research on scapular dyskinesis, and what we see with shoulder and elbow problems is that when you start to do an activity over and over again, like we would all expect, your body gets tired, and that at a certain amount of time you're going to start to have more humeral elevation and upward rotation of the scapula, and that's going to lead to certain conditions like shoulder instability, which are your impingement syndromes, your labral lesions, the things that we see so often in our upper extremity overhead athletes. And these fatigue-induced alterations that we see from this Zago paper can lead to injuries. So maybe it's not even just treating the elbow. Maybe it's just teaching the pitcher about what they can do, what they can't do, and the time frame for that. Because what happens that I see, and that I'm sure you've seen, is physiologic learning. And that's what we're trying to accomplish, is for people to learn how to move, to learn how to play a sport, to learn how to sit at their desk. And if they do that appropriately, then they learn to adapt to that stimulation. There are certain people that learn to adapt to being a secretary by doing this. And 20 years later, they have a Dowager hump, they have headaches, and they all look the same even. They've morphed into being a secretary physiologically. Learning is a physiologic response, though. You know, some people think of learning as this abstract thing. However, there's places in your body, the periphery, the dorsal horn, the brain, where you can really up and down regulate what's going on, and you can still have potential sites of therapy in these regions. Learning doesn't just happen in the brain. Learning can happen at any one of these 3 points. I guess my only question that I think that I hope to provide some information on is that how many of these sites do you impact with your patients? Because therapy should be multifactorial. It shouldn't be just affecting the joint. It should be requiring you to change their habits, their beliefs, their education, their diet. How many things are you willing to change with a patient, or how many things are you qualified to talk about and to have an impact on as a provider? Because if you're just treating one of these things, it's not good enough. It can affect some people, but not everybody. So I really think that this process of physiologic learning can really change the way we practice by having an idea of what we can do at the 3 points. So let's talk about the first point, is the primary neuron. The primary neuron, where you have pain perception, essentially. This is the area that tissue is damaged. This is where there's immune cells residing. This is where the immune cells are damaged, or at least called to action. And they say, hey, we've got a problem here. They're going to start to release cytokines. They're going to start to release these chemicals to say, hey, Brandon, there's an issue with this area. One of the important ones is the prostaglandins. That's represented here with PG. They're produced by nearly all cells, and they're a response to inflammation. So this peripheral site is the first site of noxious stimulation. Doesn't matter if you injure a muscle, doesn't matter if you injure skin or a bone, or maybe you have IBS, maybe you have a joint restriction. This is where our receptors are gonna say, hey, you've done too much, and we've created an immune response. With that though, we have a secondary neuron, and that's where you're going to see right here, where you're going to see in the dorsal horn of the spinal cord, that first order neuron is going to synapse and relay this signal saying, hey, something's wrong. Take this impulse to the secondary neuron. This secondary neuron is going to cross over to the opposite side and go up that spinal thalamic tract. From here, that secondary neuron is going to continue up the ascending tract through the spinal cord and up to the brain, and it's going to terminate in the thalamus. That's where the second order neuron is going to synapse with the third order neuron, and it's going to go up to the brain. And this is something interesting. This is something that putting this presentation together, I was like, well, we'll kind of write this one off. There's not much that you and I can do to impact things within the spinal cord. However, there are. There's a huge wind-up phenomena that happens at the dorsal root. And there are things that we can do to affect that. There are things that patients are already doing to affect that. They're going to bathe that area in anti-inflammatories. We call those opioids. We have things like CBD oil. We have things like exercise to activate the descending inhibitory pathway. I'll cover that in a couple minutes. So don't write that area off. Don't write the spinal cord area off. There's a lot of things that you can do to impact that area that we'll cover. And the third, just to finish out the pain tract, is a third order neuron. This is going to carry that noxious stimulus and relay that over to a region of the brain that's going to recognize what's going on. You hurt your right hand, we need to take that and deliver it to the brain and say, hey, brain, we've got a problem with the right hand. This is actually going to discern the area of injury. It's going to bring in a little bit of experience, say how severe is this, and perceive what's going on and what are the actions that we need to take for this. We all know from school, it's a long time ago, but sensation is always on the opposite side of the brain. So anything on the left side of the body is going to be perceived on the right side of the brain. However, with chronic pain, with persistent pain, what happens to the brain? What happens is a process called central sensitization. And this process is when the area becomes more sensitive. Your brain's getting better at discerning pain. And it does this to protect yourself. Pain is a good thing. If you didn't have pain, we would have serious issues. You would not know what's going to hurt yourself. You would not know that putting your hand on a hot stove is not a good idea. So we really need to make sure that we understand pain, but we also need to understand for ourselves and also for our patients is that this is where learning is happening. This is where the predictive system starts and ends. This is where we're going to learn how to respond, recognize patterns of stimulation, and then have an idea of what to do. As a chiropractor, as someone in conservative measures, I think this is where we have our greatest impact on patients. Not just the peripheral mechanisms, but the third order neurons. And I'm not talking about saying everything's in your head. That's not true. That's period. It's just not true. Learning can happen anywhere. And we do an excellent job at getting people out of pain by doing what we do. But if we can incorporate all three sites of learning into our treatment plan, we can really solve a lot more problems. Not only can we solve those problems, but we can keep those problems from coming back if we can do a good enough job. The good part about pain is very predictable. We're all built very much the same. So while I'm working with someone with little league elbow versus hip osteoarthritis versus Achilles tendinopathy, a lot of this is going to be automated and re-educating the patient on how this pain processing is working and the things that we can do to help with the person. Unfortunately, the current model of healthcare is that long-term treatment of chronic or persistent pain is dependent on the person you ask. And realistically, it's dependent on their payment model as far as what they're going to do for you. Some treatments for different conditions have efficacy, some don't. Some impact one site of pain and one site of learning. Hopefully we can impact all three. The purpose of today's talk is to look at the evidence and to say, what are we doing for these patients? And what else can be done? Not even just things that we can do, but also things that our patients can do for themselves, or the network of people that we've built into our system and our community that can help with this. Some people need surgery. I don't do surgery in my office. Some people do massage. I don't massage patients. Some people may need pharmacological help. They may need nutrition help. I would rather change your religion than change your diet. Changing diets is a habit. It's very difficult to do. Find an expert in your area, because what we know is that when we get into those primary neurons and secondary neurons, is that your diet, systemic inflammation, can have a huge impact on what's going on with that wind-up phenomena, with how much inflammation is present, and that we have to attack all these points, all three insertion points for this chronic ongoing pain. And this is the last piece, is that there's a lot of people that will hang their hat on a specific article, a book they read a long time ago. And there's a lot of times that those facts are still true, but there's a lot of times they're not. And I think that people will always attack, chiropractic for not being a science, but it's because we hold on to things that are historical. We hold on to a thought process we learned 10 years ago, and some of us are not willing to be humble enough to understand where someone else, maybe it's in their profession, maybe it's another chiropractor in your area, is better suited or can attack one of the other parts of this pain problem. And I think that we really have to attack all three insertion points, because what I see most often is I see practitioners of all professions trying to solve chronic ongoing problems. And they peddle some program, some supplement, something to solve chronic pain. And I said peddling, and I'll stand by that, because if you truly want to be scientific about it, there is no one thing to solve that. It's not possible, because every single person has a different experience and has learned to respond to that stimulus different. So there's no way that a essential oil or manipulation or a specific patient education piece is going to fix chronic pain. It's not going to be a hormone replacement. It's not going to be a depression medication. It's not going to be nutrition or exercise. It's going to be a combination of everything. So not one of these, there's not one single treatment for everyone. We really need to be the person in the room, the expert in the room, to go against what the public says and say, no, here's the recipe. Here's what we need to do. We need to stop pitching so much. We need to start doing this stretch. We need to ice 3 times a day. You need to take 4 weeks off. Then I'm going to get you into some progressive loading exercise. Maybe in my office, maybe think about this. Maybe the chiropractor down the street who does rehab in their office, you do the getting out of pain, they do the building up because they have a facility. Maybe you refer to the functional medicine doctor down the street who does nutrition, because that's also important in inflammation. When we can really start to look at the science and figure out what we are great at in our specific office, and then we understand what other chiros and other professions do, that's science. That's multidisciplinary care that has one person in mind, and that's the patient. So let's talk about what we can do as a chiropractor, and this is where realistically, I think we do the best job. I shouldn't say that. I shouldn't say I think. The research has shown that there is evidence to support what we do. There is no such thing as chiropractic treatment, and I firmly 100% believe that. Chiropractic is a profession. It's not a treatment. So we're all chiropractors. We all went to school at certain places, some better than others. Obviously, Logan being the tip top of the pinnacle of the iceberg. However, some of you had substandard educations other places. I'm kidding. I think that this is the one thing that I think that we shine. We attack the peripheral areas. We can mobilize degenerated joints. There's plenty of evidence to support that. We can help identify strained muscles. We can help identify when the pain is not musculoskeletal. Maybe it's an IBD. Maybe there's some muscular imbalance leading to a joint that's not centrated straight or not seated properly, creating structural imbalances, or just typical joint restriction. Maybe there's inflammation. These are the things that we know how to attack. We can see it, we can smell it, we can touch it, we can move it, and we can find a solution for that. And we can attack that primary neuron. This is where things get tricky though, is that if we don't do this and we don't do it quickly, then let's say it's a knee pain, then unfortunately it will propagate pain. So what I'm going to tell you is that don't dig your head and put your hand in the head in the sand and say, we're just going to keep on treating this knee pain for 7 months. Because if they have that chronic stimulation of that joint, in this case the knee, it will lead to central sensitization. The same thing happens post-surgically, like we see here, is if someone has a surgery and they come back to see you, what should you be doing? You should be working really hard to get that pain to go away fast, because if you don't, that pain is going to last. Their joint's not going to move as well. They're going to have their increased disability, a decreased quality of life, and that we really need to make sure that it get this pain to die down fast. Some people will frown upon the fact that I'll have someone go get an injection for certain conditions. But that injection, a steroid, is a window of opportunity for the right patient. I need to break that pain cycle. I need to stop that first order neuron from firing so much so I can allow them to do an activity for the shoulder, for the knee. I need to get them back into doing something specific. Otherwise, I'm at risk of developing a long-term pain condition for this patient. So really, what we do is so great by getting people out of pain fast. If you notice a condition is not getting better, it doesn't have to be 100% better in a week. However, if they're not getting better, that's when to not refer out. It's not to send for something else. It's to bring in someone else's insertion point. It's to talk to them about nutrition. It's to talk to them about their activity at home. It's about looking at the other insertion points at the primary neuron that we can have an impact on. Let's look at hip osteoarthritis. This is one of my, I shouldn't say my favorite lecture, but this is one of my favorite joints in the body because I feel like most of us as chiropractors are hypocrites. We say we treat everything. However, if there's one diagnosis that I see most often, mostly from a pain management department, but also from people who've seen other chiropractors, is this. It's people with groin pain, lateral hip pain, and someone's been treating their back. And maybe they do have degeneration, maybe they do have stenosis. However, you do a couple tests and you realize that with the right evaluation, their pain's not coming from their back, it's coming from their hip. If you want to know how to evaluate the hip, obviously we do all that in ChiroUp. What you'll see here on the evaluation section, if you want the most sensitive and specific test for 102, I think, diagnoses, we do that in ChiroUp. If you want the evidence-based management of how to do the passive treatments, soft tissue, nerve mobilization, manipulation, mobilization. There's videos and pictures also here. And then obviously the exercises, so what we're going to do with someone with hip osteoarthritis. And then if you're ever looking for the evidence, meaning how did I put this entire presentation together, I went into specific conditions. You can click on any one of these and it'll pull up the actual text. A literature review that's updated on a monthly basis with articles from 2020, 2019. In fact, we even thought about taking out all articles from 2020 as it's been an interesting year. But this is where you can find all the information. But one of my favorite is just this one. It's the C sign. It's understanding that when patients come in with a hip problem and they give you this presentation, the C sign, really complex test, they make a C with their hand and they put it over their hip. It turns out that this almost with 98% sensitivity identifies a hip problem and not a back problem. Now, what we know is that I believe it's between 40 and 50% of people with a hip problem could also have saphenous nerve involvement. So it can go down to the leg. However, most of the time, sign, it's right there in the groin that you'll see with this C sign. So we really want to make sure that we have the right evaluation. If I spend my time treating the back and someone has a hip problem, then I'm not moving in the right direction for that patient. Here's a great paper that came out just recently. I think that was May. And this is a chicken and egg story, is that when you have people with moderate hip osteoarthritis, they have weakness in their hips. The butt muscles aren't as strong. The purpose of this paper is to bring one thing together, and that is that if you strengthen, it will improve. Is that if you really focus on strengthening the butt muscles, you can have a lot of impact on hip patients, any patients with that being said. There's one argument that I think this paper does a pretty good job of answering also, is that stretching and strengthening, people will look at, do I stretch first or do I strengthen first? And I don't quite understand that question, and let me rephrase it in a different way. I'm going to progressively load a patient. When you stretch a patient, you're not stretching them, you're loading tissue, but you're doing it with a low load. You're using their own body, their own brain to generate a force that's going to passively stretch or load a tissue. When I start to do rehab, I'm going to start on the ground and not weight bearing, and they're going to do an activity which is also going to load that tissue. And like for this case, a clam, a bridge, a clam with resistance to add a little more load to the system. And then I'll have them go in a kneeling position to a standing position to add body weight and more load. So what you want to do, and if you go back to the slide with the condition, is you'll see that we progressively load somebody. We go from a very low load stretch to a very high load standing squat or lunge. However, with these conditions, if I were to stay in one of those very low load activities, like maybe Sally was having a pain in her hip, I made the right diagnosis, I gave her the right beginning exercise, but I stopped with like a clamshell. That's not good enough. Because if we want to strengthen tissue, I need to get her standing. I need to get her ready to go off balance. Maybe she slips on some ice and she needs to catch herself on one foot before breaking her hip. These are the things that are so important in getting somebody out of pain that I think will go a long way in our in their healing process, when you can really look at the articles and say, what should we be doing to patients? So let's talk about this pain cycle that we see so frequently in the case of hip osteoarthritis, but realistically any kind of a joint. So I want to bring your attention to repetitive microtrauma. A lot of people always think this is an activity. It's a sport, walking, running, lifting, that kind of stuff. And that's true. However, most of the repetitive microtrauma and strain we put on our bodies is due to our posture. And our postures create stress on the body, and that's okay. Our bodies need stress, but not prolonged, sustained stress. Because what we see when you do prolonged, sustained stress on a body is that it's not able to recover. It needs movement, it needs activity. And if you have that at the joint, in this case the hip, you will see swelling and synovitis because the body is responding to that stress. It's trying to heal from that stress. When you have prolonged swelling and synovitis, we'll see things like softening of the cartilage and the tissues around that joint, what we call damage. Now here's the difference. The difference is the right side of this graph is what we're going to see as far as structure. The left side is what we're going to see as far as function. So when you see this cycle happen over and over again, eventually it's going to turn this where we start to see actual degeneration of the joint, erosion of the joint, the cartilage, and the bony structures with any kind of osteopenia. And whenever that happens, you take a joint that has a nice instantaneous center of rotation where it moves, And now when you start to actually take that and you create joint space narrowing, degeneration of the joint, dehydration of the discs, or the synovial fluid, that's when the joint's going to move around a little bit too much. In the case of the hip, fits right there in the acetabulum, it's going to start to move. And those micro movements create, or we'll call it instability and deformity of the joint, where you can start to actually take a joint that says, hey, I'm moving too much, I need more stabilization. And the way that your body is going to adapt to that is through osteophytes and sclerosis and subchondral cysts, in this case in the hip, but really anywhere in your body. Those are the things we see on structure, but that's not what we're going to treat. We need to treat this instability. We need to treat the stress. We need to go all the way back through this chain to actually help this person, because we can't fix the things on the right side here. We can't fix osteophytes and sclerosis, subchondral cysts. Those things are there. They're in response to hypermobility. The same thing is going to happen in the shoulder, any other joint in your body. Laying down bone is not the pain propagation. It's the actual what causes it. What can we do? We can take away pain and we can improve mobility. We can help with weight gain. Now, there's research to support all the things that we can do to take away their discomfort. Now, they'll be left with these things. However, that's not why the patient came in. I've never had a patient come in and say, hey, I've got sclerosis at L5S1 or at the superior margin of the femoral acetabular joint. That doesn't exist. What do they tell us? I've got some tight muscles and my hip doesn't want to move and it hurts when I walk up steps. Those are the things to fix. We can't look at these things and infer their treatment. We need to do proper evaluation and assessment to affect the things that we can attack. Because the very end of that treatment plan, they're going to be left with these things. But if we do the right things, we can get the pain to go away. So people with hip osteoarthritis, these are the kind of people that have prolonged stiffness. They have pain in the groin. That's one of the biggest things. It increases with weight bearing. And we get that crepitus. That crepitus is the moving around of that joint, joint sounds, cartilage rubbing on cartilage, or other tissues that are rubbing against other tissues, like we see in hip impingement syndromes and snapping syndromes. There's a cool part about this, though. There's light at the end of the tunnel. The light is movement. It's activity. We need joints to move. And if we can get joints to move, we can strengthen tissue around it, we can progressively load tissue, we can get patients' pain to diminish. So I think that's the main purpose of this thing. And also, I think I mentioned before, is that just because they have numbness and tingling doesn't always mean that it's from the lumbar spine. It could also be from the hip joint. So don't think A plus B equals C all the time in the case of the hip with this slide. I did a blog probably about a month ago, and I just like the name of this guy, Francisco Gonzalez Espinosa de la Monteros. And I really like this blog because it fits well into what I was looking at, which is sensitivity and specificity of tests. And the main purpose of this blog that we put out, the paper just came out this year, is that don't try to associate one test with one result, meaning one diagnosis. Is often it takes a clinical prediction rule. One thing you can do is if you email me, Brandon, BRANDON, at ChiroUp.com, CHIROUP.com. I'm going to give you all of our regional exam forms, and I'm going to do that for one reason. I don't think you need to change all your regional exam forms by any means. However, take a look at the clusters of tests, and that's what this paper was about, is that often one test doesn't equal one diagnosis, but 2 or 3 tests in combination, ones that are very sensitive to catch all diagnosed in the area, and then very specific, which are going to identify the exact tissue, can really help speed up your process of evaluation. And it goes, this one is for lumbar spine radiculitis. Dr. Bertelsmann did a blog on this as far as who has chemical radiculitis versus mechanical radiculitis. And I think that once you can start to speed up your evaluation, it'll go a long way. In fact, I have the blog right here.
Hey, this is Brandon and Tim with ChiroUp. I want to give you guys some useful information since Dr. Burlesman bores you with his information on a weekly basis. Just kidding. I'm actually going to steal 2 of his blogs, one from a couple weeks ago, one from a year ago, and put together a useful blog that you can use tomorrow. That blog is based upon radiculitis, and clearly we see that on a regular basis as chiropractors. However, his blog, which I found very interesting, was on how to determine who has chemical radiculitis. And what he found from that paper, and I think it was Ford was the author in 2020, said that there are certain signs or certain symptoms you're going to have with lumbar spine radiculitis. Like if somebody has constant pain, if pain is less than a 5 out of 10, if they have nocturnal pain, if those symptoms began about 24 hours after the injury or the event that predisposed that person to pain, or if they have symptoms that are not getting better with walking, those are symptoms of somebody who has chemical radiculitis. However, we can also look for the things that are objective that we can find in our office. So what we found from my paper, from my favorite author, Francisco Javier Gonzalez Espinosa de la Monteros, just because I like saying his name, is he looked at objectively what can we do once we get those symptoms from our patients that we put in our subjective section of our note. And what he found is there's multiple tests, orthopedic and neurodynamic, that can help us say that yes, you have radiculitis versus something else. So what we can find is that the orthopedic testing and neurodynamic testing, when done in isolation, aren't that great. However, if you can look at the accuracy of those tests when performed in combination, they actually do very well as compared to the gold standard as far as MRI. So the 2 combinations of tests are the first, with being an SLR and a Bragger test. So if my pain in the butt right here is due to radiculitis, I can start off with doing the SLR, which is bringing the leg up, isolating only hip flexion, putting a lot of tension across that sciatic nerve, and looking for reproduction of symptoms. As soon as you hit that point, make a note of it, put it in your note. However, otherwise you're going to drop it about 10 degrees for the Bragger test. If symptoms go away, and then you can dorsiflex the ankle and it reproduces symptoms again, that is a positive test. There is a very good sign they have lumbar spine radiculitis. The other way we can do that, could you go ahead and sit up for me, is we can do slump and Desjardins triad. Now, Desjardins triad is not necessarily an orthopedic test. It's do they reproduce the symptoms upon any kind of coughing, sneezing, or straining at the stool. Did you have any pain on your leg upon straining at the stool this morning? And the other one is slump test. Now, I do prefer a modified slump test where I use a stool, just kind of wheel myself around the treatment room. I'm actually going to bring both of his legs up here. And the reason I go on a stool is because it's very comfortable for me. He's going to slowly slump down, and I'm going to bring his head towards his waist. And I'm looking for reproduction of symptoms, putting a lot of stress across those dural structures, and once again, looking for any kind of reproduction of symptoms. So in combination, if we can do the subjective section, which we saw from Dr. Burlesman's note, and we can look at the objective section, which is what we just went over with this paper by Francisco Javier Gonzalez Espinosa de la Monteros, we can be pretty sure someone has lumbar spine radiculitis, as compared to something else that could be presenting and causing a dull, achy sensational leg, like a hamstring strain or something else. What is a good way that I could say that this is not a lumbar spine radiculitis and say maybe it's something else, like a hamstring strain? What test do you use, Dr. Burlesman?
Classic hamstring test. A lot of times if I get fooled with the patient who has a hamstring and lumbar radiculopathy, I'll have them do a take off the shoe test. So they trap one foot on the floor and then pull their foot out of their shoe. If you're trapping that heel, that's going to recruit the hamstring. Another one that I really like is a hamstring drag test, where the patient takes their foot and drags it across the floor. I tell them to try to rub some of the sole of your shoe onto my carpet. I really want them to drag that along. And then we can do some resisted testing in a couple of different planes. We can take their leg up into a straight leg raise and have them push down into it, and then have them at a 90-90 and pull their leg out. So sometimes just getting it at a different angle. One thing to remember about those hamstring injuries is that the closer to the origin at the ischial tuberosity, the longer that patient is going to take to heal. So we got to give some time. Those are things that are frustrating and are not going to be quick recoveries for our patients. But hopefully these tests help you out and you'll learn something from somebody who's learning something.
So the biggest piece of this puzzle is we all like ducks We all like rows, but sometimes they're squirrels and they're everywhere. Something as simple as a low back pain, a butt pain isn't always as simple as sciatica. Sometimes there's multiple things we can consider. Check out ChiroUp as far as a condition reference on hamstring strain and how we differentiate that from a typical low back problem as a disc problem or spondylosis and a radicular symptom. Thanks for watching. Look forward to talking to you next week.
So thanks for checking out that video. I think that the main purpose behind that video is not to look at posterior butt pain and do the exact same thing for every single person. Instead, doing the right test to say this is a hamstring problem because they're a power lifter. This is a hip problem because they fit the age group and demographic, or this is a lumbar spine radicular symptom. By doing the right test will save you time and prevent you from having that patient that comes in by week 4 and they're not any better. I think that it's the evaluation that separates most of our clinicians, not the treatments. The treatments are the methods, the things that we do. Those are things like directional therapy, like soft tissue manipulation, like instrument-assisted manipulation, like Grasslin, like motion palpation, neurodynamics. All of those are treatment methods. It's the principles that make the biggest difference. Why you're doing what you're doing. And what we know from the research is that if you can just identify the right tissue, you can prevent propagation of pain by attacking all 3 points, not only in the periphery, but also the spinal cord, and then up through the brain. So here's the forms that I was talking about. This is for the hip. However, you can look at all of our forms and maybe incorporate them if you'd like, but they're incorporated into clinical prediction rules from the evidence to say that if you want to document something as someone having an SI joint dysfunction, those are the tests. Hip osteoarthritis, Fabry, hip scour, C-sign, FAI, femoral impingement, whether it's a labral problem or also a cam deformity. So what are the specific tests that you can utilize? Now, if you have any questions on those, on how to perform those, you can YouTube those, or you can hop on ChiroUp and we have video demonstrations of every single exercise. And then we have them lumped into the actual condition to make it simple on you to identify the condition and say, yeah, they have hip osteoarthritis. Then you can click and you can just send them the patient education directly from ChiroUp to not only have the education, but also have a load management strategy to get that person out of pain. When it comes to hip osteoarthritis, what are the top things you look for though? Limited internal rotation and a positive C sign. That's really about it. Yeah, you can do x-rays, and we have an x-ray machine in our office, and I use that for red flags or when I have something suspicious of pathology. However, utilizing the right test will save you time and save your patient money, boosts up their patient satisfaction a lot more. So limited internal rotation, you could check both passively, but also just doing a Fabry test, where you're taking them into some adduction and internal rotation. I am a chiropractor at heart. There's one thing that gets me up more than that, but we won't talk about that. Number 2 thing that gets me up in the morning is manipulation. Manipulation is powerful, especially for the hip. Here's some great studies that back up that claim. However, don't forget about manipulating the hips. It goes a long way. If they have signs of reduced mobility, if it's a thing where the hip's moving too much or they have a labral problem with an FAI, are you going to manipulate that person? Probably not. However, manipulation of the hip, whether it's with long axis distraction or a different way, mobilization, can go a long way in helping these people get out of pain. These are all ways to get that first order neuron to decrease. If you have the right diagnosis, then you can apply the right strategies. This one's a little bit older as far as 2015. However, what we know is that manual therapy works really well. Manual therapy, you can go back to the gait theory, but mechanoreception does trump nociception. And a lot of times people develop these issues at their joints where they don't move in a certain direction due to sustained load like a posture or repetitive load due to some kind of repetitive stress like pitching a baseball. We need to make sure that through manual therapy, we can regain all ranges of motion. I'm a big manipulation guy. I love to hear pops and cracks. Sometimes people need to be downgraded a little bit. They can't tolerate that at the very beginning. So in that case, I do a lot of directional therapy or more Mulligan mobilization to help with those symptoms. I told you guys I don't like nutrition, both for myself, but also for my patients, but it's not because I don't think it's important. I think it's probably one of the most important things that we can do for our patients is to lead them along a healthy lifestyle. There is a plethora of research on nutrition. However, what I found is that people will spend unlimited money to add things to their diet to lose weight and to feel better and to take away wrinkles. However, I've never seen one person pay money to take things out of their diet. So it is very difficult to work with nutrition. Here's what I do. I work with a functional medicine doctor in my area who does nutrition with my patients. It's not because I'm not intelligent enough or I don't have the education to do it. I probably could, and I could probably buy some supplements and things in a program for my office. However, nutrition is difficult. It's an all-encompassing project with your patients. That to get them to change the way they eat is to change a habit, the exact same way as to change the strength of the glutes. So sometimes taking someone who has a very specific knowledge base and skill set works much better than me dabbling in that. Also, I think my patients enjoy that a little bit more as far as having someone that's all they do. That's their specialty. What we know from ketogenic diets and what we know about sugar is that unfortunately today's diet just isn't great for chronic pain and perpetuation of pain. If we can decrease the sugar intake, if we can drop the amount of insulin in the blood, we can have dramatic impacts on pain. It doesn't mean that they have a problem with their diet. It just means the diet is perpetuating their discomfort. So something to consider. I'm pretty blunt with my patients. That if somebody has put on some weight or even lost weight, I'm going to point that out because it makes a difference. One, if they're losing weight, we need to make sure that we take note of that on what's going on, what's changed with that person. So if something significant has changed, that we can comment on it, make sure there's no red flags out there. But also, if weight has gone up, there's not something more psychological or a specific reason, a change in activity that can be impacting my care. Because what we know from this paper is that unfortunately that the more fat tissue you have, the more inflammation you have. That is impacting my care. Is that if you're not taking care of your body, you're not doing my advice, and you're eating poorly, that's going to unfortunately impact the entire system. So we want to make sure that we attack that as we're attacking everything. If we really want to make a change, a game changer in someone's life, it's really attacking all the necessary factors. When it comes to treatment of the hip, what are the things that you can do though? What are the manual therapy things you can do? I do a lot of soft tissue manipulation of the hip adductors. I'm not an ART guy, an FDM guy, a factor guy. I've been fortunate enough to take a lot of those classes. However, I find that it's whatever the patient can tolerate. So when you look at manual therapy, you really want to take a look at what the person can tolerate and then what you are certified and able to do. This is more of a movement stripping, looking at the adductors and the interface between the adductors and the hamstrings. But you can also do simple things like the actual contract relax, where she's pushing up with her knee and going back down. There's a lot of things going on here. We look at stretching out her hip, as a manual therapy to affect the primary neuron. However, we're also incorporating movement. And the more we can get tissues to move, the better off we are. Now, keep in mind with this stretch right here, if someone had a hip osteoarthritis, we could slowly get that to move further and further down. If someone had a pincer type deformity with an impingement syndrome, they're probably not going to like that very much. So when you're performing your stretches, take into consideration how the patient's responding to that. You can get a better idea about their diagnosis and what you can do and what you can't do.
Points and myofascial stripping.
We hear enough of Dr. Bertelsmann on a daily basis. We want to not hear him anymore. Just kidding, you'll have him in part 2. The STM, soft tissue manipulation of the psoas. I do more of a contractile relax where she's pushing into my knee and I'm pulling back. My hip right here is blocking her butt to make sure she doesn't get hyperextension of the actual lumbar spine. So this is another great stretch for the hip that I think works well, regardless if it's an impingement versus an osteoarthritis type situation. Mobilization. So long axis distraction actually creates a negative pressure within the capsule. So using my own body weight, what I can do is I can pull backwards and I can provide a mobilization to the hip that's great for sensitization of any kind of primary neuron. This is the way that most people are shown. This is the way I was shown in practice. I actually just have the knee bent now, and I pull at the actual knee so I can eliminate creating long axis traction from the actual tibiofemoral joint also. And then this is, most people have a loss of extension, so I can do that stretch for the psoas, but I can also mobilize the hip. I pull the patient off the table as it had, and I'm going right through that femur and providing a posterior to anterior shear at the hip, keeping the hip right there. You can see it in extension the entire time, and I can take her to end range and a little bit more to help take away some of that discomfort. So mobilization, it works well. Switch that up. Where you can't provide manipulation. Manipulation, more of a grade 5 treatment, works for a lot of people, but some people can't tolerate that right away. You can also incorporate a drop table on here and perform a little bit of a body drop down on that patient. Management of hip issues. One, make sure you have the right diagnosis like we've talked about. Make sure you have something just like a muscle strain versus hip osteoarthritis versus an impingement syndrome. And then the most important thing is to calm shit down. Make sure that that pain dies down. Avoid the aggravating factors. If we can't avoid those aggravating factors, then unfortunately it's going to keep on flaring up and creating more and more pains and problems. But if you look at the actual research, exercise. They need movement. The movement helps the joint, but it also helps things upstream from that as far as the spinal cord and the descending inhibitory pathway. And then lastly, manipulation. So manipulation affecting the primary neuron can go a long way in these peripheral problems. So all things to think about when you're attacking the hip joint. ADL advice with hip problems is to not give the patients excuses, meaning, oh, I can't walk, it hurts too much. Well, how far can you walk? Let's walk that far. Ideal weight, which we've already talked about, is that unfortunately, if you're not able to exercise, your body weight tends to increase. There's very little correlation between pain and weight, but there's a big correlation between activity level and weight and activity level and pain. So it's more about getting someone active. And the reason I bring that up is we don't need someone to lose 30% of their excess body weight. We need someone moving and on that pathway to getting out of pain. Yes, they can use a cane. Yes, they can use supplements to help in that process. But the biggest thing that we can do, the biggest piece of advice that we can give to somebody with a joint problem is to move, to become active. And the more that you can do that and be convincing in your argument to park in the back of the parking lot versus use the go-kart at Target, the better service you're providing to your patients. So that's through the primary neuron. I know I used a couple examples, one being the elbow and also in the hip, as far as how can we, with an evidence-based mind, affect the primary neuron. But now let's talk about the secondary neuron. And the secondary neuron, where the first and second synapse is going to be in the spinal cord. So we look at this as you can't touch that area. However, what can we do here and what kind of impact can we make? Because there is a wind-up phenomena that happens, is that when you start to release substance P into this substantia gelatinosa, unfortunately we need to say, hey, that's enough. We don't need more activity. That yes, I can do my my manual therapy and manipulation and everything to stop the source of pain, but if this process has been going on long enough, then these tissues are used to releasing substance P and accepting substance P without the descending inhibitory pathway, without any kind of regulation. Then we're going to have this pathway open to the brain, and people don't like that. They don't like to have pain. So what are the things that people use to stop this pathway? Opioids. Whether we like it or not, they work. They do a very good job of blocking the release of substance P into this area and to stop this pathway. Now, I personally believe that if you don't stop that primary part, then this is the next step. If you don't think spinal cord stimulators work, then you're incorrect. In fact, they're one of the most successful ways to block these things from happening in the spinal cord. They're very invasive, very dangerous, and sometimes they don't work. And that's why opioids became so popular, is by the expense of spinal cord stimulators. But there's other things that we can do. Even there's a lot of research on CBD oils and CBD products to help in this process that aren't as addictive or dangerous as an opioid as far as the risk-benefit ratio. So what else can we do to affect the secondary neuron? Well, here's a really cheap, easy one. This was from a paper from, I think it was in Pain Medicine, I know it was, from 2017 or 2018. But there is evidence to support the psychological aspects of the descending inhibitory pathway. And you know these patients. You know the patients who are very optimistic. The people are very... there's always the glass is half full kind of people. However, what they found is that the people who are very optimistic and use exercise-induced hypoalgesia, that they did really well, meaning they were actually able to decrease the amount of substance P released to increase the descending inhibitory pathway if they can actually do some exercise and feel good about it. So I really think that this is one of the cheap, easy ways to do our job a little bit better. That I think that one thing we can do is affect the mood of our patient, and that has to do a little bit with that checkmark patient at the very beginning. We have to give them hope. We have to say, if you do this, then you will receive this. If you start to walk more, you will have less hip pain. If we can get this, if we can strengthen your elbow flexors, we can decrease the amount of pain you'll have in your with your golfer's elbow. So providing that hope, along with providing the actual recipe to get someone out of discomfort, was our load management strategy. As far as load management, most people consider that their rehab or their exercises, shifting them from an activity that doesn't hurt them quite as bad to an activity that's going to start to rebuild tissue depending on their diagnosis, fits well within the secondary neuron. This paper was 2014, I think it was. However, central sensitization is that process by which an ongoing peripheral event where you have injured tissue creates nociception that goes from primary to secondary to tertiary, which we call centralization. If you can break that linkage, if you can break any piece of that, you can have an impact on central sensitization. And the simple fact is certain things like acetaminophen, like serotonin reuptake inhibitor drugs, norepinephrine, serotonin, those are kind of things that we can actually use to break that. Now, I don't believe they're long-term solutions, and you've seen this with your anticonvulsants and your depression medications. Is sometimes they do have a short-term relief, but if you don't break the entire chain, you just prescribe a pill and you say, good luck. Then your chance of getting people out of pain in the long run, I think, is about as good as you adjusting somebody and their pain of 5 years has gone away. It can happen. However, it's more of a targeted approach, meaning you can't just do one thing and expect a long-term result. So instead, a common medical practice is just to keep on prescribing the pills. Whereas that may not be the best strategy from what we're seeing in the research. The same as just providing manipulation every visit and expecting a long-term resolution of pain. It takes more. So to affect the secondary neuron, yes, pills, medications can work to affect the pain processing center at the spinal cord. However, you also have to affect the primary neuron and the tertiary neuron. And that's probably not best done with just more medications. So, sometimes using an anti-inflammatory and a muscle relaxant can help in the short run. But let the patient know this is a window of opportunity to help get you out of pain. This isn't a long-term solution. This is going to help get us to where we need to go. And making sure they understand this isn't the end all be all. Exercise. God, if we can just get everyone to exercise a little bit more. But if I said, hey, you need to exercise, my compliance is going to drop pretty fast. Instead, developing some simple exercise at the beginning that will affect that joint, if it was the hip or the elbow or the foot, we want to make sure that we can give them something that is affecting that area that they think is hurt, even though we would understand that this is a total body process. Things like injections. When I do speak in person, I ask people, do you think epidural steroid injections work? And most people say no. And that's just not the case. Epidural steroid injections do work for a certain population, a demographic of patient, and they don't work on many more. But it's the same process, is that nobody gets an epidural steroid injection and then comes in to see us and says, hey, Dr. Steele, I just saw Dr. Smith at the hospital, had an epidural. Everything feels great, just came in to see you. Instead, they come in and say, no, I had an injection and it didn't work. What can you do for me? Well, the same thing happens in chiropractic. They come to see you for 4 visits, 8 visits, and it didn't work. So they go see the primary care doctor, the pain management doctor, and they say, oh, you saw a chiropractor, it didn't work. That's all they see. They see our failures. We see their failures. But it's not to say that each individual treatment didn't work. It's that one method didn't work for that one person in isolation. Instead, if we can take an epidural injection, we can couple that with manipulation and the right exercise and the right patient education and maybe the right pharmacologic, we can impact all the pieces of that patient's pain processing puzzle and to help get them out of pain. So never be afraid to ask for help. But one thing that I've noticed that's helped build my practice is to not just refer out. Instead, refer for a treatment. Hey, I need to get an epidural steroid injection L4-5. The patient has this finding on their MRI. They're doing well in care, but I think this might help get them out of their discomfort right now. So it provides a window of opportunity for me to do some rehab. That's a much different experience for a pain management doctor as compared to, hey, I didn't help them, see what you can do. I think that one of the things that we can also provide is, the exercise component of what we do. People don't want, in today's world, to go to physical therapy for an hour every day and pay $300. It's very expensive and it's very time consuming. If you can provide the same exercise programs at home with pictures and video descriptions, it saves your patient time and money, and I think it goes a long way as far as patient compliance. The last, and I'm not the expert at this, I think I just told you with nutrition, but there is a lot of evidence on CBD oil. It's a safe alternative. I didn't include a lot of research from during this conversation. However, I would recommend doing that as it seems to be the newest trend. What else can we do to affect the secondary neuron? And I think that what the papers that I've read is that there are certain tricks that you can do to help people. One is attention, meaning that when you really focus on something, you can put attention towards one part of your body, but you're essentially distracting the other part of your body. One thing I'll do, and this is the picture of that, but shoulder pains and problems are often a result of a lack of stability, and especially at the shoulder blade. So one thing you can do is you can have someone actively activate the serratus anterior, lower trap, middle trap, and retract their scapula. And as they're focusing on that retraction of their scapula, yes, that changes the position of the shoulder, and yes, it does some balancing out of muscles and opening the subacromial space. But what they can do is they're focusing on that, and now they can move their arm better. I did an interesting talk with Michael Bracchio as part of the ACA Rehab Council on grasp, holding, and I forgot the paper. He brought it up in his lecture, that if someone has shoulder pain, just tell them to grab something and hold it harder, grasp it harder. And I'll be damned if it doesn't work. You're essentially affecting the attention or distraction aspect of the brain. If they're focusing on one thing, it'll take the pain away from something else. Distraction is another thing, is that if you can actually have people focus on something else, focus on a repetitive task with the right hand and you elicit reflexes on the left side, your body will divert all its attention to the active cognitive activity as compared to the other stuff that you're doing for, both at the spinal and supraspinal level. So I think that's something else you can take advantage of. I think that distraction, there's a really cool blog I put out it was the beginning of this year on running. And I love to go through and to look at people's gait styles and how they run differently. And I'm actually at fault of trying to change too much. And this paper said that if you take a look at somebody with patellofemoral pain and you have them start running, there's a lot of things that have been shown in the literature to help with that, like changing a crossover gait or widening your stance or run at a faster speed to engage the posterior chain, the glutes, to run uphill, to run faster speeds, lower speeds, higher cadence, lower cadence, arm swing, position of your head. There's a lot of different things that you can do with patients during their gait to provide an optimal gait. And they found that some of that does work a little bit, but if you get them to try to focus on too many things, then their pain actually goes up. If someone has knee pain, you have them focus on their knee, their pain increases. If you have someone try to focus on something else associated with their mechanics, their knee will start to hurt. But if you have them watch a movie, have them focus on something else, they'll often have less pain. So there's something to be said about just changing one or two of the big elephants in the room with any kind of movement dysfunction, and then see if you can have them focus on something else and distract them from that. And it'll go a long way as far as getting them out of pain. I think that the increase in vulnerability stress. I forgot why I included this paper. What are we talking about? Is that frailty syndrome. Don't let your patients think they're frail. Is that as we have people age, they will become weaker and they will have both a physical and a mental decline associated with their age. However, don't let that feed into the words that you use, because your words matter. Having someone say, well, I'm just getting older, I can't do this, I can't get on the floor. How debilitating must that be to not be able to get on the floor? I think that would be horrible. For me to know that if I drop something on the ground, I can't get it. Start to train those things. One, don't let that enter your mouth, or leave your mouth, I should say, as far as, oh, I understand you're getting older. And we need to do things to protect people, like using a cane or a walker. However, don't fall prey to, I'm getting older, I need help. Help them by getting them to move. Help them by challenging them physically and mentally to get them out of their pain, because the research shows is they need both of those things to prevent that degenerative process. Some people do need to know their limit, though. At some point, you got to stop driving if you can't actually perform the task. So be cognizant of people's limitations, but also don't let their excuses dictate what you're going to do with your patients. We're on to the last part. The last part is the top, the brain aspect, the third order neuron aspect of treatment. And this is where we connect that thalamus to the somatosensory cortex. And I don't know about you, I'm not a brain surgeon, so I don't pretend to be. However, people perceive pain differently. They get these patterns of stimulation in, and then there's an output out. And if you have a pattern of stimulation that when you walk up steps that it hurts your right knee, you're going to start to move your knee differently, or stop walking up steps, or buy a new house, or buy a knee brace, or buy Copper Fit, it fixes everything, or rub some essential oils on it. You're going to find a strategy that you think helps to change that pattern of stimulation. So there are things that you can do that are evidence-based to also do the same thing, instead of just falling prey to a gimmick. The first, which I think is the most important, is Mosley and Butler's book, Explain Pain. I don't know when this came out. I know I was in school, so probably a decade or better. I mean, that's when I read it. It's probably older than that. And I thought it was kind of a goofy book because of the graphics and the pictures. But then you start to read it, and you start to realize that humans are adaptable, that humans, as far as anatomy and physiology, are adaptable, and that we have a lot of biological interdependence. We have a lot of adaptable pieces and redundancy built in that if something happens to us, we're going to find a way to get around it. It's kind of like we're going to do things based on our survival. If I have a broken leg, but there's a tiger chasing me, I'm going to find a way to move. And the things and the pathways that lead to our chronic and persistent pain, our ongoing pain, are often adaptable in the same way that we got it. And that's attacking all the different pieces. It's not looking at, yes, you have pain that's been going on for a long time. It's how can we make this process change? And that's where we come in with our education and our rehabilitation to help stop those individual pieces and break enough of those patterns with evidence-based platforms to get people out of that ongoing pain. Often it's not education, it's re-education. We have to, first and foremost, stop talking about pain and structure. It's just wrong. It's just not correct. Is that a lot of patients believe they have a pathoanatomical source of pain. Now, if you have a broken femur and it's sticking out of your skin, that's the cause of your pain. But when it comes to degenerative conditions, the research is clear. And I don't want to discount and say that's not the source of your pain, or it's not a cause of your pain. It probably is a cause. It's causing stiffness. It's causing the muscles to work harder. One thing that I do with my patients, I say, listen, you've got some arthritis there, and it's kind of like the rusty hinge on the door. Is that when that is rusty, the muscles have to work a lot harder to move that joint. And unfortunately, when they do that over and over again, it sometimes causes stiffness and pain. I'm going to get those joints moving better. I'm going to get it loose. I'm going to give you the rehab to keep it loose, and then we're going to use some strategies to help prevent it from happening again. So I think that there's a lot of things that we can do to help with these painful conditions, but I don't focus on, oh my gosh, you've got this severe degeneration at L5, S1. We need to do something significant to get this pain to go, this arthritis to go away, because unfortunately, there's not a solution to get arthritis to go away. So re-educating your patients and reorienting them with solutions that do work. So exercise, I think, is the biggest piece of this. I tell people to go take a walk outside more so than really anything else. I think psychologically and physically, there's a lot of benefits to exercise, to movement. However, sometimes people have a foot pain or a problem that's aggravating this. So we have to get them back to walking outside while taking into consideration their current pain or problem. So finishing up, what are we going to do with our patients who are having symptoms and that's limiting their ability to move, especially getting outside and walking? One of the integral things that all of our patients must do is get up, move, and be active. So I think that this is where I want to end the discussion, but going into the knee just a little bit, because I think that the knee is one of those things that often limits people's ability to be active and mobile, thereby affecting peripheral issues, spinal cord issues, and also brain issues psychologically, as far as what they think they can do and what they don't think they can do. You guys remember this from the hip, but the thing is that this graph works so well in every part of the body, and these stresses leads to the same thing. Over time, we get osteophytes and sclerosis and cysts with any joint that's going through any kind of degeneration. So yes, you need to tap someone on the knee and say, yes, I understand you have arthritis, but we still need you moving. We need you being active. Because what I know with the elderly is a third of them have arthritis. That's a big deal, is that if they're having some kind of arthritic conditions, when someone tells them psychologically they think, I've got this arthritis, I can't be active, that becomes a big problem because they see this as a progressive problem and that it's probably not going to get better unless they get what? A knee replacement. How often do you hear in your office, oh, I just got a get through this until I have the thing replaced. That's a bad psychological state. It's a bad physiological state, because there's a lot of things that can be done for the knee maybe it's not the arthritis causing their pain. Maybe it's the load on their knee. Maybe they have an imbalance on the knee that we can, as far as the muscles, ligaments, or joint restrictions, limiting the ability to move and putting abnormal stress on the different compartments that are showing wear and tear. Keeping in mind that it's not always just the knee joint. It could be hormonal, or it could be something like body habitus. I think I mentioned that before, but it's not necessarily the weight, it's the activity associated with the weight that affects so many of these conditions. Stress on the actual knee isn't that great with obesity until you start to flex the knee, until you start to move the knee, squats, lunges, steps, and that's where we're going to see most of our pains and our problems. Also post-surgical stuff, and we'll see that in today's world with the current studies is that they aren't repairing the degenerative meniscus anymore because of the trauma on the capsule and the internal structures and cartilage, that they're not repairing those things. And the repairs that we are seeing are taking advantage of the body's own healing ability. So if they see things like microfractures create inflammatory reaction in the knee and let the body heal itself. But we do see accelerated osteoarthritis due to trauma and due to surgery. And it's not just knee replacement anymore, that it used to be just replace the whole thing. There's a lot of stuff that we can do in our offices to prevent surgery, or at least delay surgery with the rehabilitation exercises and plans. One of the things is to look at what the person's doing. And that if they are doing an activity that requires sustained pressure on the knee, developing a load management strategy that's going to take the stress off the knee will be critical to get them out of pain. I think that one of the things that I hear is people stop doing activities because it hurts. I think that's a poor strategy. And in fact, people that do run for long periods of time, for one example, but they could also be lunging or playing badminton or pickleball. Once they have a pain, they stop doing that activity because that's when it started. And I think that's a poor decision. It's up to us as evidence-based practitioners to assess the problem and then hopefully get them back into their sport as fast as possible. Just because it caused pain with running doesn't mean to stop running. I think that knee osteoarthritic conditions often get confused with patellofemoral conditions, which are reversible, fixable, manageable, and also meniscus type pains. One of the ways to differentiate that when you look at the orthopedic evaluations and functional evaluations is how they squat. People will say they have pain when they squat. However, really dive deep into that, and most of your patellofemoral pains are going to be when they're going down or coming back up. It's not until they actually fully squat down and they hit that end range of that knee that you're really going to be stressing or shifting that meniscus, where you get meniscal pains at the very bottom of the squat. So take that in consideration during your evaluation and also your history taking process to make sure you understand where they're having pain. Because our meniscus are there to be shock absorbers. There's fibrocartilage that actually increases the surface area of the condyles on the top and bottom from the femur and also the tibia. And then we need those. Those aren't just meant to be taken out. Unfortunately, they, once they're gone, 50 to 75% of that axial compression going on from bone to bone only increases. So we want to keep those for as long as possible, and hopefully understand that for some meniscus injuries, they're repairable and that we're able to recover. There is some blood supply out in the vascular part of the periphery of the meniscus. It's not the whole thing.
Just dissected it.
It looks a lot like a disc, but what you can see from the vasculature is it doesn't go all the way out into the horns, and when we start to see tears, bucket handle tears out in the periphery, unfortunately, without the blood supply, it's not going to recover. It's only on the outside part of the meniscus, as indicated here in the red and the white zone. The white zone being, of course, the area that's not going to recover. The cool part about the meniscus is we don't really know this, but it actually moves. It translates 5 to 7 millimeters based on what your knee is doing, and go forward with your extension and backwards with flexion of the knee. So the meniscus are designed to move a little bit to help absorb those forces. We normally see these on males. It's possibly thought that males have more active of jobs, which should cause more physical laborious jobs, which is why we see this a little bit more often. But the cool part is not usually till later on in age when you start to see degenerative tears, and you see more of your traumatic tears in the earlier years with fast twisting and distraction type moments. But it's not often you see a problem with the males as compared to females. Females tend to have more incidents of injury as compared to males. Different types of meniscus tears. I don't remember any of these. I send all my MRIs out to a radiologist. However, there are certain tears that aren't going to get better, like your radial tears once they've hit a certain point. But unfortunately, once they get into those white zones and they're on the periphery there, they're not going to get better. And they are usually a sign of one, just clipping it off, or two, removal completely of the entire meniscus, which you're not seeing as many times. We'll see degeneration on the right-hand side, which is a little more prevalent and non-repairable. But sometimes we'll see the torn flaps where the knee will actually lock with a twisting maneuver, and those are usually anchored down surgically. The common presentation, though, of a meniscus injury is like I said, at the end range of flexion. The catching and locking, they're going to feel, that means there's probably a flap that's been doubled over, and those are the things where we get that sensation of buckling, catching, that we want to send someone over to surgery, because if that can be removed, then hopefully we can get them back to squatting fully. Our presentation of meniscus injuries are younger patients, traumatic injury, sudden twist, whereas degenerative, it's usually not a specific event. It's been going on for a while. Here's the cool part that the research is showing is that joint line tenderness, one of the easiest tests to perform, as you poke on it and it hurts. Also, we'll see Baker's cyst, and that's because that fluid is leaking out due to that inflammation out of the capsule into a space in the back part of the knee. So that's a sign of an internal derangement of the knee when you start to see swelling on the outside, which will obviously be limiting your range of motion from the swelling, but also with meniscus tears, you're not going to get the same range of motion that you would. Knees that are locked in flexion, unable to get extension, could be a meniscus problem, but more than likely age-matched, more of a degenerative condition. Whereas a patellofemoral issue, they're going to move it all around until they put a lot of stress on it. With a terminal knee flexion, are you going to feel a patellofemoral problem? How do you evaluate it? So this is one of those things that I want a quick way to assess. Is this degenerative as far as osteoarthritis, or is this patellofemoral, which is more poking on it, patellofemoral region, hypertonicity in the quadriceps, or is this an internal derangement, which is like a meniscus problem, because they all have very different strategies to help get them out of pain. Iggy's test, which I think is a video here, they're going to have them squat with their toes out, really stressing the inside part of the meniscus, and then having the toes in, which stress the outside or lateral parts of the meniscus. And when you can do this, you can have a really good sensitivity, I think in the 60 to 70%, and specificity between 81 and 90% for acute tears of the meniscus. So this is one of my favorite tests. Popping, clicking, catching. You're really going to test all aspects of the meniscus, both medial and lateral, anterior and posterior, with Iggy's test. We can also do Thessaly Tests. This is the one that I'm going to use in the office. I'm going to support her, and she's going to take her knee back and forth. So internal and external rotation. Once again, looking for popping, clicking, pain. It's about 94 to 96% sensitive for a meniscus injury. So you're loading that tissue and then you're twisting it back and forth, really grinding that tissue. So I even like this better than a McMurray's test. So those are the kind of the things that I'm going to look for a meniscus injury as compared to an osteoarthritis. And then it comes down to, so if I have a true peripheral problem, what am I going to do with this kind of a patient? Well, if it's patellofemoral, or if a meniscus problem that's non-surgical, that's stuff that fits into my office. If it's something that's a meniscus problem that's really swollen, I'm still going to be treating it, but I need them to take a little bit of time off. If it's degeneration that's very severe, limiting all ranges of motion, severe pain that's chronic and constant, what can I do for that patient? A lot of times I can do some manual therapy, but a replacement might be on the table. Whereas a meniscus problem and osteoarthritis may be an injection on the table. So by having the best possible diagnosis, you can really tell the patient what's available to them, what you can do for them, and then what other providers can do for them. Most of your acute tears in a young population need surgery, so it's in with my best interest and the patient's best interest to let them know that listen, we can get a lot of these these people better. Up to a third can be treated conservatively. However, a lot of these people are going to need surgery, but letting the person know that up front will go a long way. If they have any kind of locking with that Thessaly maneuver, with that Iggy's maneuver, with squatting, then we can say that this is probably a surgical case. I can still treat them, but a vast majority of these are going to move on into a surgical realm. So I think that that surgical referral drops with age. If someone just has arthritis, I'm not sending them to surgery. Once the knee is so bad they can't do things, it's impacting their life, it's impacting that third order neuron where they're having centralization of symptoms, then I'm going to say, you know what, this is the benefit of having surgery is greater than the risk of being sedentary. So I think that's something also to consider for your patient's best interest. The surgery may be a good option for them with the recommendations from the evidence. Home care, if you have any kind of meniscus irritation, stop irritating it. Get it to calm down. Take some pressure off it. Orthotics do a good job on not letting the feet roll in, forcing internal rotation and spin from the femur and the tibia. So avoid those things that are going to make it worse. And also, while osteoarthritis and intra-joint inflammation isn't best dealt with non-steroidals, it will help take the edge off the pain and get somebody moving. Because if you have a true meniscus problem, you're not able to load weight the same. So doing landscaping outside probably isn't a great idea if on the weekend you want to see your grandchildren. So kind of keep in mind of your patient education is your capacity has diminished. So to keep in mind with the patient to make sure they understand their condition and what they're doing or maybe not doing to help themselves. So at the end of this, what I'd like to kind of focus on is that knee pain isn't knee pain. Knee pain could be patellofemoral, it could be meniscus, it could be degenerative, it could be something else. That when we look at the signs and the symptoms, we need to make our best guess as to the diagnosis with the best orthopedic test possible. If they're younger and they have patellofemoral pain, maybe they're 10, 12, they're a soccer player, think about Oscar Slaughter. Have those buckets of diagnoses. If you have any questions over there, obviously we keep all that in ChiroUp as far as the best practice evidence and recipes for every single diagnosis, but it still takes you're the most important cog in that wheel to have an idea. So we can give you the 20 diagnoses of the knee, but you still need to match up the subjective with the objective. We can give you the load management strategies and the patient education, but it still requires the astute clinician to come up with the diagnosis. And then give them everything they need, because in order for you to help them with their condition, they need to understand their condition just as well as you do. So they need to know what to do and what not to do to help with their symptoms. And I think that as long as we can do that on a regular basis, we can prevent people from doing activities that are aggravating them versus being afraid of activities because they think it might hurt. I would always hate to tell somebody they can never walk again because of their knee osteoarthritis, or that they have a shoulder problem and I don't want them on the floor, or they have a knee problem and I don't want them squatting, or back problems, I don't want them being a carpenter. People have to work just like I do, just like you do. We need to make sure that we can fit into their world, and we can do that with our therapies and with our education, and hopefully on the recipe that we give them to get them in and out of pain, or not into pain, out of pain. But even when we do get people in pain, it still tells us we're hitting the right structure. I tell this to a lot of patients, and some people give me a little bit of a look, but when they come in after that first visit, and the one thing that I don't want to hear is nothing changed. If they got better, obviously that's the best possible situation. But even if they get worse, at least we're hitting the right structures. We might have just done a little bit too much too fast. When people aren't getting better at all, that's when I really want to move up and down the stream to say, yeah, that's a tissue that gave way, but something else is causing it. Just a little tip. As far as ChiroUp and everything that we do, it's all just based on knowledge transfer to see if we can get people, as far as chiropractors, a little more efficient than what you guys do as a provider. I'm a practicing chiropractor. Anything that can save me time and energy and still give my patients the utmost satisfaction, the better. We do that at ChiroUp. We do it to make sure that you're just as efficient. If you ever want to give ChiroUp a try, go to ChiroUp.com and sign up for a free trial. It doesn't cost you anything. You'll have free support, and it's a software as a service. So we have a 98% retention rate. People that use us like us, and it has nothing to do with something special we do. It's just that we do it all and we try to do it perfect. So patient education, exercise rehabilitation, load management strategies, teaching you how to hopefully do the best possible orthopedic exam, neurologic exam, and then of course having some a way to take those successes, your clinical successes with patients, and transferring that to the real world, meaning patients are surveyed and they put actual Google reviews on Google for you. We give them patient satisfaction surveys. They have their own app they can actually view everything on and educate themselves on their condition, and it's all based around clinical success that starts with your diagnosis. I want to thank you for attending this seminar. This seminar was a general overview of how we think and how we do things in our practice and also at ChiroUp. I would highly recommend seeing Dr. Berlesman's part 2. It is 2 hours with him, and he's going to go through several specific, like I did with osteoarthritis and knee, but he's going to go each specific condition. Here's how to evaluate it. Here's how to treat it. Here's patient education. Here's the rehab. Here's the videos to everything. He does a phenomenal job in everything that he does. He really makes it understandable and hopefully find an easy way for you to treat patients in your office and add a piece to your clinical care that's going to help your patient satisfaction.